Well, hello, and thanks for the kind invitation to speak today about direct transfer to the angio suite. We really advocate for this measure since we believe it saves precious time, and I'm going to talk about it and tell you why. Here are my disclosures. So, when we think about the time spent from symptoms onset to groin puncture, we usually believe that the bulk of the time happens at the pre-hospital level. However, this nice study, including almost 7,000 patients, shows us that the total time that was spent in the hospital accounted for almost 40% of the time from symptoms onset to groin puncture, meaning that yes, we can do many things to save time at the pre-hospital level, but also there's a lot of time that we're spending in hospital that we might probably shorten to achieve earlier recanalization. I think that the objective should be around 30 minutes, either for direct admissions or for transferred patients from another primary stroke center, as compared to the usual 60 to 90 minutes that most of our comprehensive stroke centers are spending in the door to puncture process. And obviously, time is brain either at the pre-hospital level or the in-hospital level. Now, this is basically what we need to do when we admit a patient from the ambulance in order to confirm that he needs a thrombectomy, to rule out an hemorrhage, a large established infarct, and confirm a large vessel occlusion, right? But the methods we might be using to do so might differ either if we are at the beginning of the symptoms onset or in a later time window. Now, the classic workflow, which does not include any more taking the patient to the ER, I think this is out of question. We should avoid as much as possible admitting initially the patient into the ER. It's, in my opinion, it's a complete waste of time. So the I would do the circuit, the workflow that is used most of the times would be go through the conventional imaging, CT or MR, and after confirming the imaging criteria, we would take the patient to the angio suite and initiate the puncture. But we believed that we can shorten the process by taking the patient directly to the angio suite, and that may obviously shorten groin time, the door to groin time, but it might have additional advantages as we're going to be discussing later. Now, just as a background, we developed this study in which we collected all those primary admissions in our comprehensive stroke centers in Barcelona, and here is the distribution of the aspect score according to the time from symptoms onset. And you can see that yes, effectively, there's a decrease as time goes on with a rate of perfect aspects of 10. However, the rate of aspects above 5 is really high during the first 6 hours and does not go below 10%. So very few patients do have an aspect score that might jeopardize or contraindicate with the current guideline criteria the endovascular treatment. Now, many groups in the last year, since 2017, have published their experience taking the patients directly to the angio suite. And I think now we might be convinced that it's an effective way to reduce time. Because as you can see here, the median door to groin times that these groups achieved range from 17 to 33 minutes as compared to 70, 60, 65. So basically we are saving around 40, 50, 60 minutes time in our workflow time. We still need to demonstrate that this is an effective measure, but yeah, we can believe that that it might be so. But we at this point we were still missing confirmation. Now, we also recently published this nice study with that included only transferred patients, meaning that they had a previous imaging at the local stroke center, in which you can see that in those patients in which image was repeated, either in the early window or the late window, they all had worse outcome. So basically it means that if there is a previous image at the at the local stroke center, unless there is a dramatic change in the neurological status, either an improvement or a deterioration, we probably should not repeat imaging, since yeah, it's probably just a waste of time. And here also you can see the impact of time. Obviously doesn't seem so. I like this graph, but let's spend a minute here. So why do you think that there's no impact of time in those patients in which the image was repeated? And this is not exactly true. What happens here is that when you repeated the image, you just excluded those patients that would have made the curve going down. So this is why the orange curve is just straight, and the patients in which you are not repeating the image seems to decrease the outcome. But obviously the impact of time is the same for all the patients. Now, let's talk about the Angiocat study that we recently finished and published, and with which we wanted to finally bring a confirmation of the efficacy in terms of outcome of going directly to the angio suite. So we decided to randomize patients on admissions either to follow the usual workflow, going through the conventional CT and eventually to the angio suite, or straight to the angio suite. We call the study the Angiocat, and we included the following patients. We only wanted to include patients within 6 hours from onset. We believe that beyond 6 hours, the effect of going directly to the angiosuite might not be so high, since the time reduction, the relative time reduction will not have such an impact, or the same impact if it's with a total time of 6 or 7 hours or with a total time of 1 or 2 hours, obviously. So this is why we included only patients within 6 hours from onset in the study. Patients we had to have a pre-alert by EMS, and we should confirm the immediate availability of the team and the angio suite. So we should be ready to take the patient directly to the angio suite. Everybody was ready, and on arrival, if we confirmed at the doorstep that the patient had an NIH greater than 10, he would be randomized for the Angiocat study. As shown here, he would be randomized to either of the two options, and finally patient would be treated identically the same and follow up for 90 days. So this is the chart in which we finally randomized 174 patients, 89 and 85 to each arm, and of those you can see that the vast majority did had a confirmation of a large vessel occlusion. So very few patients with an NIH greater than 10 will finally not have a large vessel occlusion, and we called those with a large vessel occlusion the modified intention to treat, in which we tested the final hypothesis of improved outcome. Now here you can see all the patients, and you can see that the rate of primary admissions versus transfer was basically one primary for each 2 transferred patients. We had 8 or 9% rate of hemorrhage with this rate of transfers, and finally we could confirm the large vessel occlusion, as I said, in more than 80% of the patients. And that would be the modified intention to treat. This is also very interesting. Here you can see, according to both arms, when a large vessel occlusion was observed in the direct transfer, we treated with endovascular treatment 100% of these patients. However, for those patients that went to the conventional CT, only 87% received an endovascular treatment, meaning that in a few of these patients we considered probably the aspect was too low, or there was some kind of imaging contraindication, basically low aspects, to undergo endovascular treatment. And this might be an additional source of disparity of improved outcome for direct transfer to angiosuite. That is another hypothesis. Not only the time reduction, but also we are going to be more prone to treat the patients since he is already on the table and we are ready to do the treatment. Now you can see at the short-term outcome how there was a trend towards better outcome for those patients in direct transfer to the angiosuite, and again we confirmed a large time reduction, 42 minutes versus 18, so meaning 24-minute reduction in the in-hospital workflow time until the door in the door to groin puncture. And finally, here we have the distribution of the ranking, the primary efficacy outcome that turned out to be positive, an odds ratio, adjusted odds ratio of 2.2, meaning a benefit towards taking the patient directly to the angio suite. There's a nice shift towards better outcomes in the upper row. So what needs to be done today to establish direct transfer to the angio suite as the gold standard for the treatment of suspected LVO? First, you might ask us to confirm our results in a single center study, in a multinational, international study, in which we could evaluate the impact in different, not in very extremely organized center like ours, but also in other centers. And yes, we are going to perform this with a WITRA study that recently started to randomize patients in 16 centers around the world. We hope to have the results in less than 2 years. Obviously, you need to have a pre-alert by EMS. If you are not pre-alerted that the patient is coming, and this pre-alert should come with some kind of pre-hospital scale, we use RACE, but we can use any of those that are described. You need to be pre-alerted to get ready, otherwise you are not going to be able to do so. So pre-alert with RACE kinds of filters these patients with probably non-LVO stroke patients. They will receive the alert, and we are prepared at the hospital when the patient comes in. At this point, we perform a very fast NIH assessment at the doorstep, and if we confirm an NIH greater than 10, then the patient can be taken directly to the angio suite. So that way we avoid transferring those patients with lower NIH, in which probably many of them do not have a large vessel occlusion. So we are not advocating to take all the patients directly to the angio suite, only those with high probability of large vessel occlusion screened by pre-hospital scale and specialized vascular neurology that does the exam on arrival. Now, we need also adequate imaging quality. We cannot perform this strategy with cone-beam CTs from many years ago, and you're going to understand that this quality that is a few years old is not sufficient to take decisions. Nowadays, we have ways to optimize the image that is acquired at the angio suite. We can have such images. As you can see here, it's very easy to identify an hemorrhage that would cause an NIH greater than 10. You can evaluate very well the early ischemic signs on these kind of CTs. So this is, if you don't have comparable quality of imaging, you probably shouldn't do that. But most of the vendors today are reaching this degree of quality. Obviously, you need immediate availability of the angio suite, and this is not always evident in centers that only have one angio suite. So we are advocating, first, to educate all the team that it's an increased amount of work for these guys that work in the angio suite. We need to educate them, make them understand how important is what we are doing here. We don't want to stress too much the team. Obviously, at night, if we want to do that, we should consider activation ASAP, even before patient arrives, and get there before patient arrives. But I think this adoption of direct transfer should be gradual in a center. You should not expect to go from 0 to 100%, and it should be progressively. And probably we are never going to take 100% of our patients directly to the angio suite. We're going to reach a plateau in which 60, 70, 80% of the patients will do that, but not all of them, obviously, because sometimes there are reasonable doubts about the presence of an LVO just with a neurological exam. Also, as I said, you need immediate availability of the angio suite, and that may happen if you convince your management that you need a dedicated angio suite for these patients. And in centers like mine, in which we admit over 1,500 stroke patients per year, we perform more than 300 thrombectomies per year, it makes reasonable sense to have a dedicated one-stop shop in which we could take all acute admissions admissions, acute stroke admissions to that angio suite to perform everything there, imaging, stabilization, IVTPA, and then we initiate thrombectomy if needed, and if not, we transfer the patient outside. And this angio suite would be used 3-4 times per day in my center. Now, here are a couple of examples from the WITRA study in which you see in a patient that was allocated to go to the conventional arm, we did a good job. The door-to-groin time was only 40 minutes, which is remarkably low, I think. However, this is another patient that was allocated to go directly to the angio suite, and which we still did even better. We achieved a door-to-groin puncture as low as 11 minutes. So still, we are reducing 30 minutes here, which obviously should have an impact in outcome. Now, a last example of the quality of the imaging that we achieved in one of these patients. I think it's pretty good. You can evaluate yourself if this is sufficient to take decisions or not. And here's to finish an example in which you see that everybody is coordinated in the angio suite. We go very fast. We transfer the patient to the table. Now we're going to be acquiring the cone beam CT. Here we acquire the cone beam CT. We evaluate the parenchyma. And in our case, here we are within 5 minutes, we are ready to initiate the groin puncture. In our case, we diagnose the presence of an LVO with an angiogram. But if you want, you can also perform a cone beam CTA that would increase 2-3 more additional minutes the workflow time, but it, on the other hand, it will avoid some groin puncture in which the patient will not have a